Okay, so when we're talking about the nerves of the thyroid gland, basically, let's talk about the vagus nerve. The vagus nerve gives one branch in the upper region, which is known as the superior laryngeal nerve, and then it comes below, and then it gives the recurrent laryngeal nerves, which hook around different structures on right and left side. So, superiorly we have the superior laryngeal nerve, and inferiorly we have the recurrent laryngeal nerve. Now, the superior laryngeal nerve gives the internal laryngeal nerve and the external laryngeal nerve. The internal laryngeal nerve is basically going to give the sensory supply above the vocal cords, and whenever it is damaged, there is going to be paroxysmal nocturnal cough and aspiration, because the mucosa is going to be, its sensory supply is going to be disturbed. Whereas external laryngeal nerve is mainly motor, it supplies the cricothyroid muscle, which is the tensor of the vocal cords. And if it is damaged, then there's going to be loss of timbre of voice, and there's going to be husky voice. Okay, hoarseness is not going to be there. Okay, so the external and internal, we know what happens when they are damaged. Now let's talk about the recurrent laryngeal nerve. On the left side, it hooks around the arch of aorta, and on the right side, it hooks around the right subclavian artery, and it gives the sensory supply below the vocal cord, and also supplies all the muscles except the cricothyroid. Okay, and now what happens, it also supplies the posterior cricoarytenoid, which is a safety muscle of the larynx, and it causes abduction. Now, the thing is that when it is damaged, whether it's damaged unilaterally or bilaterally, when it is damaged unilaterally, then there's going to be there's going to be hoarseness, which recovers within 3 months. But if it is damaged bilaterally, then the abduction is going to be lost, and the cords are going to be adducted, and the cadaveric position is going to be there. So in that case, there's going to be stridor, and you have to intubate the patient. Like after the thyroidectomy, you have to re-intubate the patient and wait for 24 to 48 hours. And if it's not recovering, you have to do tracheostomy. And for long-term solutions, we have the option of arytenoidectomy and the permanent lateralization of cord. Okay, because it's a very dangerous situation. Now, so we were talking about the external laryngeal nerve. We know that it supplies the cricothyroid, and if it is gone, then there's going to be loss of the timbre of the voice. Now, what is the most commonly injured nerve out of these three nerves? External laryngeal nerve. Okay, it is the most commonly injured nerve, and it is present, and it runs at the upper border of the superior pole. Okay, this is the superior pole. It runs at the upper border. And what is the distance between the nerve and the superior pole? We determine by the Cernia classification. If it is more than 1 centimeter, then it is grade 1. If it is less than 1 centimeter, it is grade 2. We have 2A, which is the nerve is above the gland, or 2B, the nerve is on the gland. Okay. Let's look at a different image. So we were saying that the superior laryngeal nerve gives the internal, and the external. Internal was supplying the mucosa above the vocal cord. And so what is the pathway? The internal laryngeal nerve pierces the thyrohyoid membrane, and then it gives the sensory supply above the hyoid bone, right, above the vocal cords, and it passes through the thyroid and hyoid. Now, which artery does this internal laryngeal nerve accompany? This is an MCQ point. It accompanies the superior laryngeal artery. Okay, the superior laryngeal artery. And the external laryngeal nerve, it basically supplies the cricothyroid muscle. Okay, and we know the Cernia classification, it is the most commonly injured nerve. Very important MCQ point. Okay, then we are going to talk about the recurrent laryngeal nerve, which runs in the tracheoesophageal groove. So here I was saying the most dangerous situation is when there is bilateral damage of the recurrent laryngeal nerve in the thyroidectomy. So during surgery, how do we identify it? We have this tubercle of Zucker, tubercle of